Mute. Okay. Sir, good afternoon to all. And today's my talk is pre-operative considerations in SICS. Am I audible, sir?
Yes, sir, very clearly.
Okay,
Go
okay.
ahead, sir.
So there are number of techniques for SICS. And slides are not moving, I think. Yes. Manual SICS, I have divided these SICS techniques in three. Number one is Camp SICS. Number two, customized SICS. And number three is smart SICS. As far as Camp SICS is concerned, our main aim is for doing number of surgeries, protect the endothelium as well as posterior capsule. But when the point of customized SICS is there, along with protection of endothelium and posterior capsule, the main point is control of astigmatism. So means it is total customized surgery individual for the patients. And for this control of astigmatism, I am talking here about control of astigmatism, not reducing the astigmatism, because in every case, I want minus 0.75 to 1 diopter of myopic astigmatism. So for that, sometimes we have to increase astigmatism, sometimes we have to decrease astigmatism. So I'm talking about control. And these controls can be done by these 10 commandments I am going to follow here. Number one, fresh and sharp blades. Number two, site of incision. It should be on the basis of keratometry with the rule, against the rule, superior, even inferior or inferior temporal or nasal. Size of incision depend upon grade of nucleus, nuclear sclerosis 4, 5 or 6. With the help of radial cuts, we can also manage the size of incision, shape of incision. It should be straight, frown or chevron. Chevron will causing least amount of astigmatism. Depth, it should be 50%. Less than that or more than that, less will cause buttonholing. And if it is more than 50%, premature entry chances will be there. Size of tunnel, corneal part of tunnel should be more than 1.5. If you want to keep the astigmatism under your control, then you have to have more than 1.5 millimeter of corneal part of the tunnel. Entry and extension of outer, we have to manage it accordingly. Entry in AC and as well as extension. If you fill the AC with visco and then extend, that will cause reduced astigmatism. And if you start extending after entry, the control of astigmatism will not be there. The size of incision should be pre-planned. But even when we fail to manage the nucleus delivery and we extend it, then again, it is not under our control. No struggle in tunnel during lens delivery. These are the 10 commandments I have written down just to control your astigmatism. So this smart SICS is software guided surgery. So all considerations will be taken by software only. Some special considerations I'm like to mention for intermission cataract, high molecular weight visco, dye, micro scissors, as well as forceps. For posterior polar cataract, comparatively smaller axis, maybe we require to put our IOL on the axis. Preferably, one should not do hydrodissection, although Dr. Vindra has just started doing hydrodissection in PP also, but we generally avoid it. For deep and sunken eyes, prefer temporal site, extension at the neck for good exposure. For myotic pupils, Coughlin hook, viscomydriasis, Malugan B-hex, iridectomy, and sphincterotomy. Thanks for patience hearing.